Hello, now we will discuss about hypophosphatemia, hyperphosphatemia, hypomagnesemia, hypermagnesemia. What is hypophosphatemia? Phosphate levels less than 1 to 1.5 mg per dl. Phosphate is used for ATP production, that is energy production in the body. If it is reduced, there will be cell lysis or hemolysis and hemolysis. Causes of hypophosphatemia are malnutrition, malabsorption, refeeding syndrome, Fanconi syndrome. You know what is refeeding syndrome? In malnutrition babies, if you feed abruptly with a full caloric diet, then there will be refeeding syndrome, in which you can see hypophosphatemia, hypokalemia, etc. So there will be severe hypophosphatemia in refeeding syndrome. So never feed the malnourished babies, severely malnourished babies, with the complete caloric diet from the first day. You should gradually increase the calories. Signs: muscle weakness, peripheral neuropathy, hypotonia, paresthesias, seizures, coma, cardiac failure, rhabdomyolysis. Since main problem is in ATP production, so it is energy dependent, so it will affect all the muscles and cells. Muscle problem is muscular weakness and peripheral neuropathy, hypotonia, paresthesia, seizures, coma, cardiac failure, rhabdomyolysis, and cell lysis, hemolysis can also be seen. So mainly it will affect all the muscles, cells, nerves, because energy is needed for all the bodies. So mainly all the body muscles, cardiac muscles, cells, everything will be affected if there is severe hypophosphatemia. If asymptomatic, oral therapy is sufficient. If symptomatic, for oral therapy there will be tablets of phosphate. 1 to 2 tablets per day is sufficient. IV therapy symptomatic, that is due to muscular weakness if the patient is ventricular dependent and if there is cardiac failure, then symptomatic therapy, and in severe refeeding syndrome, then IV therapy is needed. It is 0.1 to 1.5 millimole per kg per day as continuous infusion. If you can't give IV therapy, then phosphate enemas are also effective. So this is about hypophosphatemia. Hypophosphatemia is less than 1 to 1.5 mg per dl. It's mainly used for energy ATP production. So all the body parts, all the body muscles, cardiac, CNS, nerves, muscles are affected, leading to muscle weakness, hypotonia, CNS symptoms like seizures, coma, nerves like peripheral neuropathy, paresthesias, cardiac failure, and cell lysis, rhabdomyolysis, hemolysis can be seen. Mainly etiology is malabsorption, malnutrition, refeeding syndrome, Fanconi syndrome, that is type 2 renal tubular acidosis. Fanconi syndrome is type 2 renal tubular acidosis. So this is about hypophosphatemia. Next we will come to hyperphosphatemia. It is seen in acute renal failure and chronic renal failure and tumor lysis syndrome. What is tumor lysis syndrome? When there are bulk tumors like Hodgkin's lymphoma, non-Hodgkin's lymphoma, etc. When if you give therapy, there is huge cell lysis. Cell lysis will be there because from the cells the phosphate and potassium are released, leading to hyperkalemia and hyperphosphatemia. So this is tumor lysis syndrome, which is the complication of oncological therapy, mainly seen in bulk tumors like Hodgkin's and non-Hodgkin's lymphoma. So in acute renal failure, chronic renal failure, tumor lysis syndrome, for in injurious use of phosphate enemas. So if you use overzealous use of phosphate enemas, okay. Clinical features are result from associated hypocalcemia. So whenever there is phosphate levels increase, their calcium levels will decrease. Both are opposite. So clinical features are mainly because of hypocalcemia, like seizures, coma, and also renal osteodystrophy. Because due to hyperphosphatemia, there will be hypocalcemia leading to renal osteodystrophy. Fluid administration therapy is treatment is fluid administration for under diuretics to eliminate the phosphate from the body. IV calcium if the seizures are present, mainly due to hypocalcemia. The IV calcium should be given. Phosphate binders can be effective in tumor lysis syndrome. Allopurinol, systemic alkalization, and rasburicase can be effective. This is hyperphosphatemia, mainly tumor lysis syndrome, renal failure. Mainly symptoms are due to hypocalcemia. IV calcium administration is treatment and fluid administration. Next we will come to hypomagnesemia. Is mainly due to diuretic usage, Bartter syndrome, Gitelman syndrome, malabsorption, and prolonged diarrhea. Okay. Symptoms are seizures, tremor, tetany, nystagmus, and arrhythmias. Seizures, tremor, tetany, nystagmus, arrhythmias. Okay. Mainly CNS, muscular, smooth muscle, and cardiac muscle, skeletal muscle. Seizures, tremors, tetany, nystagmus, arrhythmias. ECG, short and QT interval, ventricular tachycardia, torsady pointis, and arrhythmias. So hypomagnesemia is one of the cause of arrhythmias. Okay. Treatment if seizures and arrhythmias are present: 25 to 50 mg per kg of 50% magnesium sulfate. What is 50% magnesium sulfate? Is 1 ml contains 500 mg of magnesium sulfate, so it should be given 25 to 50 mg per kg over 15 to 30 minutes with ECG monitoring, mg per kg. Okay. Repeat if necessary every 6 hours. Correct calcium and potassium levels if low, because hypocalcemia and hypokalemia are associated with hypomagnesemia and can exaggerate the complications. So this is hypomagnesemia. Diuretics, Barters, Gitelmans, and main complications are seizures, arrhythmias. So ECG, short and QT interval, ventricular tachycardias, and torsady pointis. Treatment is 25 to 50 mg per kg of 50% MgSO4 over 15 to 30 minutes. Can be repeated. Next we will come to hypermagnesemia, seen in renal impairment and iatrogenic overzealous use of magnesium sulfate. Clinical features are, muscle weakness, mainly respiratory muscles, hypotonia, hyporeflexia. So here also muscles depression, CNS depression can be seen, and hypotension can also be seen. Treatment: stop magnesium supplement, calcium is a direct antagonist to magnesium, so calcium should be, IV calcium can be given. Diuresis, hydration with IV fluids to eliminate the magnesium from the body, and finally if refractory, dialysis should be given. So hypermagnesemia lead to muscle weakness, respiratory muscles, hypotonia, hypotension, whereas hypomagnesemia, it will lead to excitability, tremor, tetany, nystagmus, arrhythmias. Here there will be hypotension, cardiac depression, CNS depression, and muscular depression. So this is opposite. Hypomagnesemia, excitability; hypermagnesemia, there is depression. So in hypermagnesemia, calcium supplementation, diuretics, hydration should be given, whereas in hypophosphatemia there will be muscular weakness and depression in all. Okay. Whereas hyperphosphatemia, okay, this is This is about hypophosphatemia, hyperphosphatemia, hypomagnesemia, and hypermagnesemia. Thank you.